Good morning, everyone. So, first of all, I would like to thank the organizing committee for giving me this opportunity to present my work. So, I'm Dr. Neha Singh, Senior Resident from AIMS, Gorakhpur, India. Today, I will be presenting my work entitled Mathematical Pathological Approach as a Novel Tool for Prognosis in Breast Cancer. So, the breast cancer, it remains the most commonly diagnosed malignancy and the leading cause of cancer-related mortality among the women worldwide. According to the Globocan 2022, it accounts for 23.8% of newly diagnosed cancer and 15.4% of the cancer death in women globally. However, if we talk about the Indian scenario, in India, the burden is even greater, accounting for the 28.2% of all the female cancer and 24.1% related cancer related death. Moreover, in Indian women, they have the tendency to develop the breast cancer nearly a decade earlier than the women in Western countries, with the peak incidence of around 50 to 54 years of age. So this alarming statistics, it highlights not only the need for the earlier awareness or the screening, but also for the accurate prognostications. So let's now briefly review the current prognostic markers and their limitations. So currently the prognosis is based on the combination of clinical pathological features such as the tumor size, nodal status, and the grade, together with the molecular markers including ER, PR, and HER2 status, and the Ki67 index. More recently, multi-gene assays and the circulating biomarkers, miRNA, they have also emerged. However, these approaches still have the limitations. They do not accurately predict the outcomes at the individual patient level, and often they fail to account for tumor heterogeneity among the patients with the similar disease characteristics. So, there is an unmet clinical need for a robust, objective, and individualized prognostic model. So, this brings us to the mathematical pathology. It is an emerging branch of mechanobiology where the mathematical modeling and the physical principles they are integrated with pathology to better understand the disease behavior. So, instead of relying solely on the morphology, it quantitatively evaluates the biological characteristics of the tumor also. So, our study they focused on such parameter that is the diffusion penetration length. So, what exactly is the diffusion penetration length? So, it represents the distance through which the molecules, such as the nutrients, um, oxygen, or the chemotherapy agents, they diffuse within the medium that is the tumor tissue. So, it is greatly influenced by the two factors. First, the physical, biophysical, and the chemical properties of the molecules itself, and other as the nature of the tumor, that is the tumor architect, cellular proliferation or apoptosis, and the physical properties of the tissue. Therefore, this diffusion penetration length may reflect the biological behavior of the tumor more accurately than the conventional parameters alone. The objectives of our study were straightforward. First, to calculate the diffusion penetration length in invasive breast carcinoma using a mathematical pathological model, and second, to correlate it with the conventional clinical pathological characteristics and the surrogate molecular classification. So we conducted a cross-sectional study including the 30 patients with the invasive breast cancer at the VMMC and Safdarjung Hospital, New Delhi during the time period of 2018 to 2021 as a part of my thesis. So all the newly diagnosed breast cancer they were included in this study, and the sarcoma, pre-malignant lesions or metastatic lesions of the breast they were excluded. So we include in our study, both the specimen true cut biopsy and the MRM specimen, they were included. So the represented tumor sections, they underwent the routine histopathological examination together with the immunohistochemistry of ER/PR, HER2/neu and Ki-67. Additionally, the percentage of tumor cells showing positivity for Ki-67 to calculate the proliferative index was calculated by the hotspot counting method. Similarly, IC for cleaved caspase-3 was put to calculate the apoptotic index. So, in our mathematical pathological model, three patient-specific parameters were incorporated. First was the proliferative index, that is the fraction of the cell in the proliferative stage, that is the fraction of the cells showing positivity for Ki-67 ISC. Apoptotic index, that is fraction of the cell in the apoptotic stage, that is the fraction of the cells showing positivity for cleaved caspase-3. And then the geometrical mean tumor radius, that was determined by the mammography. So using these variables, diffusion penetration length was mathematically derived. Thus, every patient had an individualized quantitative measurement. So, in year 2011, the Christine et al. They developed this analytical solution to calculate the surgical volume in the in situ tumors, where they kept the three parameters were there. A, that represents the patient specific ratio of cell apoptosis to the proliferation rate within the surgical volume. The L is the diffusion penetration length, and R is the mean geometrical mean tumor radius that was determined by the mammograph. The definition of this parameter where the A was equal to lambda A by lambda M, that is the apoptotic rate constant divided by the maximum mass growth rate constant, and also lambda A was equal to apoptotic index divided by the constant duration of the cell death process, that is 6 hours, and the lambda M was equal to proliferative index divided by the tau p, that is the constant duration of the cell cycle, that is 18 hours. So by putting all these values and considering that in the invasive breast carcinoma the tumor size is generally large, the equation simplified as diffusion penetration length equivalent to AI divided apoptotic index divided by proliferative index into geometric mean radius divided by 1.1. So our result it showed that around 60% of the cases were the premenopausal, however the 40 was the postmenopausal. Around 47% of the cases the upper outer quadrant was involved, and around 63.3% of the percent were the true cut biopsy, and the 63.7% were the MRM specimen. So, and also talking about the grade, around 70% of the patient they had the grade 2, and the 45.45% the patient was in the stage of the 2A, followed by the minimum percent of the case of the 99.09%, they fall into the category of stage 2A. Sorry, 1A. Now, the talking about the surrogate molecular classification, the luminal B cases were 53.3%, and the luminal A was 10%, with triple negative was 23.3%, and the HER2/neu enriched case was 13.34%. Now the proliferative index, it has the wide range varying from the 9.4 to 87.5%, with the mean value of 52.15%. And apoptotic index, the range varied from 1.23 to 78.26%, with the mean value of 14.27%. Talking about the diffusion penetration length, it ranged from 0.03 to 2.47 mm, with the mean value of 0.48. Diffusion penetration length in association with the surrogate molecular classification, the triple negative, they had the shorter diffusion penetration length of less than or equal to 0.1 mm. And HER2/neu, it has the 0.1 to 0.5 mm, luminal A 0.5 to 1 mm, and the luminal B had the wide range of 0.1 to 2 mm. So In relation to the ER positive HER2 negative diffusion penetration length, the mean value was 0.69. However, in the ER negative HER2 positive cases, the mean value was 0.23 mm, and triple negative it was 0.05 mm. And this diffusion penetration length, they show the strong correlation with these categories with p-value of 0.006. So now, nutshell, in our study, there was a strong correlation that was found between the molecular subtype and the diffusion length with p-value of 0.014, and with the ER positive, HER2 negative, ER negative, HER2 positive, and the triple negative categories, the p-value was 0.006. However, there was no significant correlation was found with the tumor size or the nodal involvement or the stage and the grade. So, talking about the discussion, if we talk about the proliferative index, triple negative breast cancer, they demonstrated the highest proliferative activity, followed by the HER2 enriched luminal B and finally luminal A. This pattern, it reflects the aggressive biology of triple negative breast cancer and the HER2 enriched tumor characterized by rapid growth, poor differentiation, and the greater invasiveness. Our study was consistent with the previous report by the Khanna et al. Interestingly, the triple negative breast cancer, they showed the lowest apoptotic index for whereas the luminal B, they demonstrated the highest proliferative index. Lower apoptosis, they indicates the enhanced invasiveness of the programmed cell death, which contributes to prolonged tumor survival, greater metastatic potential, and poorer clinical outcomes. Again, these findings, they agree with previous study by the Faramani M. et al. Perhaps the more interesting observation involved the diffusion penetration length. Aggressive tumors, particularly the triple negative breast cancer, they demonstrated the markedly shorter diffusion penetration length, which reflects their high proliferative activity and increased metabolic demand. Conversely, luminal tumors, they exhibited longer diffusion penetration length and greater variability. These observations may also explain why the aggressive tumors often respond better to chemotherapy despite having the poorer prognosis. So our findings, they suggest the several important clinical implications. Diffusion penetration length could become an objective quantitative biomarker, it may assist in patient stratification, may support the treatment planning, and may also predict the response to the chemotherapy and potentially contribute towards the new biophysical classification of the breast cancer, because the required parameters that are being used are routinely available in the pathology laboratories, and this approach is also relatively inexpensive and feasible. So, to conclude, our study has demonstrate that the diffusion penetration length has significant association with surrogate molecular classification, and it reflects important biological characteristics of breast cancer. Although larger validation studies are certainly required, it may this approach show considerable promise as a novel prognostic parameter for individualized breast cancer management. Ultimately, integrating the mathematics with pathology may move us one step closer to truly personalized oncology. So, these are my references. Thank you very much for your attention. I would be happy to answer any question. Thank you.